Good evening all. My paper is titled External Subretinal Fluid Drainage for Atypical CSCR with Extraretinal retinal detachment. Atypical CSCR is rare and the data on their specific incidence is limited. It is characterized by a bullous inferior retinal detachment, and this prolonged detachment can lead to irreversible photoreceptor damage. So our study design, it is a retrospective analysis of a case series between the period of 2017 and 2025 at a tertiary care referral hospital, and out of 31 eyes diagnosed as atypical CSCR, 5 were taken in for the study. So the inclusion criteria, all cases of diagnosed CSCR which was confirmed by multimodal imaging was included, and those eyes where conservative therapy or laser monotherapy was not viable were taken into the study. So these are the multimodal imaging modalities that was used. And as for the surgical procedure, after 360-degree conjunctival peritomy was done, the recti muscles were tagged and hooked and tagged, and a partial thickness clearal window was made. After which an AC maintainer was put in so that the globe does not become hypotenuse during drainage. And just before drainage, an indirect ophthalmoscopy is done so as to assess the area of maximum detachment, and drainage is done with a needle. As we can see here, there is subretinal fluid which is coming out from the site of drainage. Post-operatively, angiography was done on the post-op day 1, where any new or residual leaks were identified, and focal laser was done to them, and the patient was followed up with OCT at 1 week and 1 month post-operatively. So the outcome measures, the primary outcome that we looked into was complete resolution of the subretinal fluid and retinal reattachment. We also looked into the best corrected visual acuity changes, any complications or recurrence of the condition. The BCVA was compared pre and post operatively. So this is a table which shows the patient demographics. The mean age of presentation was about 48.8 years. In our study, 4 were males and 1 was female, and none of the patients had any history of systemic steroid use. This is a table which shows the clinical characteristics of the patients, the 5 eyes, in which eye 3 has been highlighted, in which the patient had an initial visual acuity of counting finger 1 meter, which had improved to 6/9. And these are the results. We found that all the patients had complete restriction of subretinal fluid and retinal reattachment, which was confirmed by OCT. There was visual stabilization, meaning that the initial best corrected visual acuity was similar to the post-operative one, and there was no recurrence of extraordinary detachment over the mean follow-up of 32 months. As for the complications, one patient had a retinal incarceration, which was treated with a segmental buckle, and one patient had mild vitreous hemorrhage, which was managed conservatively. So this is the I1, in which an inferior detachment can be seen, which can be seen in OCT as well as the B scan. An angiography was done in which a focal leak can be seen in the superior retina. We tried laser to it, but there was no resolution of fluid. Hence, we took up the patient for the surgical procedure. Post-operative day 1, an angiography was repeated, and we can see new areas of focal leak in the inferior retina, which was previously masked by the bullous detachment. And post-operatively, 1 month, the retina was attached, and the OCT showed no fluid. This is I2, in which similarly an inferior extraordinary detachment is there, which can be seen on B scan, and OCT showed subretinal fluid along with the fibrin-like material at the macula. Angiography showed a few areas of leak to which laser was tried, but there was no resolution. Hence, the patient was taken up for surgery, and post-operatively 1 month, the retina had attached, and there was no fluid. This is the third case which I had highlighted earlier, in which the patient had an extraordinary detachment. OCT showed the presence of fluid, and angiography showed a RP rip in the supranasal quadrant, but there was no laserable areas. Hence, we took her up for the surgery, and post-op day 1, and a focal leaking area was seen in the inferior retina, to which laser was applied, and down the lane in post-op 1 month, the patient vision had significantly improved, and this is a post-op OCT. Similarly, I4, in which the inferior detachment can be seen. A few areas of focal leak was there, to which we did apply laser, but there was no resolution, and this patient was also taken up for surgery, and post-operatively 1 month the retina had attached, and there was no fluid. This is the last eye, in which this patient presented to us with a superior scotoma. He was actually advised for vitrectomy from elsewhere with the diagnosis of rhegmatogenous retinal detachment. We did a multimodal imaging, which showed us that the diagnosis is actually chronic CSCR, atypical CSCR. So this patient Angiography did not show any laserable area, so we took him up for surgery, and following which few suspicious leaky areas were seen in the angiography, for which laser was applied, and 1 month post-op his retina was attached and his visual acuity had also improved better. So discussion, atypical CSCR is a diagnostic challenge owing to a similarity between rheumatogenic and inflammatory detachment. This is the case where this time when multimodal imaging comes into play, and we found that SRF drainage followed by angiography and focal leak was helpful. So this is a similar study which was done by Shailaja Bondapati et al. In 2015, which is similar to our study. So the key findings of our study is that surgical complications are there, but it is preventable and manageable with careful technique. There is visual stabilization for all the patients. There is complete resolution and no recurrence of the condition was found. And why it matters is that it is an unexplored territory, that is atypical CSCR, for which external drainage is being done. It has not is been poorly documented, and it is stable. And this is one eye in which the patient was with atypical CSCR, in which the patient was managed conservatively, and he had a visual acuity of counting finger 1 meter. And this is our patient for whom we did SRF drainage followed by angio and focal, in which she improved to 6/9. These are my references. Thank you.
First point is like this exudative RDs, when the patient lies prone, there will be shifting of fluid.
Yes, sir.
So it's going to be collecting over the posterior pole. So the periphery will be flat now. So how to drain that, number one. Number two, why to bridle and go for a cut down? Because nowadays, if at all you want to drain, we can drain with the non-val 23 or 25 or 27. So that will give a complete thing. My worry in this case is you have bridled all the 4 muscles.
So actually, we depending upon the quadrant in which there is maximum detachment, we tag those 2 muscles.
Okay,
basically.
but 360-degree peritomy done in all cases?
Most of the cases.
Yes. No, 45 case. The reason is, how can you put the contact lens on POD1 in this size? Because it will be painful. Contact lens to do you have done, as
Yes,
per your methodology, it says on POD1 you have done the lasers.
Yes.
So when we are putting contact lens in literally post-operative traumatized eye, it will be even more painful, number one. And number two, in 5 cases where you have shown post-ops, you said one case had retinal incarceration with buckling later on, but that picture was never seen.
So buckling was done, like we found retinal incarceration just after drainage, so
Yes.
we did buckling on the same time itself.
Yeah, but we could have seen at least the buckle height or the site of
So that
incarceration.
because I didn't have the peripheral photo of that patient.
No, that laser, how it was done?
So laser was done post-op day 1 itself. We had put in Paracaine 2-3 times. Then the patient was able to manage it.
Patient will manage.
It's like they didn't complain also. They didn't have much pain. That is what we
Don't say they didn't have pain.
Okay, what was your inclusion criteria? Was it just the chronicity and your diagnosis, or was there the height of the fluid which was included as inclusion criteria?
We didn't check the height of the fluid. What we looked into was that if it is a case of CSCR, can we do laser? So if laser was not possible, or even after laser there was no resolution of fluid, then we would take up the patient for the surgical procedure. Or if after an angiography there is no laserable leaks, then we would take up the patient. We didn't look into the height of the fluid, but definitely if the macula was involved, we would have done it earlier.
And how far posterior did you have to go and drain?
Sir, it was we went maybe just beyond the just close to the equator, near the equatorial area. That is it, sir.
Just like what Naresh sir was asking,
Yes, sir.
didn't the fluid go posteriorly when the patient was lying down? So how did you manage drainage there?
The fluid did go posteriorly, but we did a careful IDO. We looked at the area which was maximum fluid accumulation was there, and then we did a scleral cut down, and then we did the drainage. Most of the fluid did come. So what we found is that the next day, post-operative day 1 itself, the rest of the fluid had gone. Even though some fluid was remaining, the next day it had resumed.
And did you give any tamponade? No air, no gas, nothing.
It was just an external drainage procedure. We didn't go for AC maintenance was good so that the growth doesn't grow hypertrophic.
Thank you.